You are listening to the Move the Dirt podcast. The information provided in this podcast is for educational purposes only. It is not intended to provide medical, legal, or any other professional advice. You should always seek advice from an appropriately qualified and experienced professional.
Hello, everyone. Thank you very much for tuning in. Today, I have the pleasure of being joined by Dr. Heidi Klessig. Heidi is originally from Wisconsin in the US and has joined me to talk about an incredibly important topic. Now, I did want to start this podcast by giving the listeners some prior warning that we will be discussing a very emotional and sensitive topic today, namely brain stem death and organ donation. I feel personally this is a very important topic. I have been very lucky to have read Heidi's book, which I'm sure we'll talk about. And without further ado, Heidi, thank you ever so much for joining us today and welcome.
Thank you so much for inviting me. This is a privilege to speak with you.
Pleasure. For perhaps any listener who is not familiar with you and your work, may I trouble you to give a brief introduction to yourself to start with, and then we'll move on into specifics.
Certainly. I am a retired anesthesiologist and specialist in pain management, and I really did not seek to become a bioethics speaker. I really didn't seek to become someone who has investigated very completely the ethics of organ donation and transplant. This stemmed from an unfortunate experience that I had during my training in anesthesiology. Back in the late 1980s, when I was being trained to become an anesthesiologist, I came in one night for my night call duty and reported to the operating room desk, and the doctor sitting there said, "Oh, Klessig, glad you're here. We want you to go up to ICU. There's a brain dead man up there that we'd like you to bring down to the operating room and anesthetize for organ harvesting." Well, I was a little shocked. I was a little unprepared. I remember feeling that, I must have heard a lecture about brain death somewhere along the line, but at that very moment, I didn't have every fact at my fingertips. So I asked him, I said, "Oh, brain death. Is there anything different about this case that I need to know?" And, he laughed and he rolled his eyes and he said, "Just be sure someone has actually declared the man brain dead. You know how eager the transplant team can be," which was not what I wanted to hear. But I took a deep breath and I went up to ICU and I found my patient. He was a young man about my own age at the time, and he had been in a severe motorcycle accident and he had sustained a severe traumatic head injury. And yes, the neurologist had seen him and had gone through all the boxes on the brain death checklist and had declared him to be brain dead. So I went to see my patient, and the first thing that went through my mind was how glad I was that he was alone in the room and that his family was not there. If you've ever had surgery, you're an anesthetist, you say in the UK, I believe, or
Yes,
I would say
indeed.
The anesthesiologist comes in and we examine you and we go over our plans and we tell you how we're going to take good care of you and we're going to do everything we can to keep you safe and comfortable and give you a good outcome. But what would I have said to his family for a patient who wasn't coming back? I was glad it was just the two of us, right? So I took a look at him and, he didn't look dead. He was warm. He had a good skin color. He had good blood pressure, good heart rate. He had nearly 100% oxygen saturation in his blood. He looked really like every other ICU patient I'd taken care of. And in fact, he looked better than most. He wasn't on much for drips or drugs or infusions. Took this information and I went back down to the operating room and I found the staff anesthesiologist who was going to be supervising me for the case. And I presented the facts to him. So he said, "All right, so Heidi, what's your anesthetic plan of care?" So, it goes to show how very brainwashed I was at the time. I told him, I think I'll give the patient a paralyzing agent so he doesn't move during the surgery. Why a dead person should be moving apparently never crossed my mind. But I didn't want to upset the surgeons because when someone is moving, when they're trying to operate, it makes it more difficult. So I was going to use a paralyzing agent. And then I said, I think I'll give him some fentanyl as a potent painkiller to blunt any swings in his heart rate or blood pressure that might damage his organs. And so my attending said, well, that all sounds very good. Are you going to give him anything to block consciousness? I was stunned.
Right. Okay.
I said, why would I do that? Isn't he dead? And, my attending just gave me a long look over his operating room mask, and he said, why don't you give him one just in case? And he walked away.
Wow. So
I'll tell you.
he clearly knew that. I mean, this to coin in a phrase, that this clearly wasn't his first rodeo. So
Right.
you have a senior colleague who knows something that you perhaps wouldn't know as a junior at that time, and it's almost as if they see nothing.
Right. And that's
Wow.
and that's on him, but it's also on me, because to my shame and regret, I did what I was told. Here I was being trained to think a certain way, and apparently this is the way we do things. There was an operating room team, there was a surgical team. Everyone was waiting for me to bring the patient down and get the case going. I just caved. I caved under the peer pressure, the idea that, well, maybe all these people know or see or understand something that I don't, even though my gut was telling me there's something very wrong with this. So I did. I brought the young man down and I gave him the anesthetic we had proposed. And I can tell you, he reacted to the incisions, the bone saw, the removal of organs, just like anybody else. He required exactly the same types, the same amounts of anesthetic drugs as anyone else. And I told this story later to a friend of mine who is a pathologist, and she said, Heidi, when I remove organs in the morgue during an autopsy, I don't need to give any of these drugs. So
Right.
it was this experience that then motivated me later in life after I had time to think about it to research more into the origins of this idea of brain death and find out what it was all about, actually in hopes that I could justify my decision at that time. Unfortunately, what I found was that all the facts, studies, and evidence are quite the other way.
May I just ask, Heidi, you mentioned that you were quite surprised when you went up to see the patient by, I don't want to use the term how healthy they looked, but I think if I recall correctly, you said that they looked very much like any other patient that you would be looking after. Did you notice any difference at all? Was it literally the case that that person could have been being wheeled off to have their tonsils removed, or maybe an orthopedic operation? Was there anything that perhaps if you hadn't been told in advance, perhaps you couldn't really draw a distinction between a patient who was about to have organs removed and perhaps any other type of operation?
The patient that I saw, the young man, again, I mentioned that, he was warm, he had good skin tone, he had stable vital signs, was excreting urine. He had a urine bag and I could see the yellow fluid running out there. I mean, the man absolutely had metabolism. He was taking in oxygen through his lungs. He was breathing out carbon dioxide on the monitor. If you would have fed him,
Right.
he would have digested food. I mean, he was certainly neurologically injured. This was a man with a poor neurologic outcome. But is lack of neurologic function the same thing as being dead? Historically, people have understood death to be the separation of our immaterial part, right? Our soul, spirit, or life force from our material body. And because we don't have any device to see the departure of an immaterial spirit, we don't have a soulometer, for instance.
Yes.
People historically have used the lack of heart rate and the system of breathing as evidence and the passage of time, right? You have to wait a certain time to be sure these things won't recur. But That's how people have decided whether that immaterial part had left. And in the past, actually, it was important to wait long enough to be sure, right? But now our definitions of death have changed to declare death as quickly as possible for the sake of organ retrieval.
I think that's a very important point there that you mentioned, because I think there are certain things in life, and particularly modern society, that we almost take for granted. So I think if you ask the average man on the street, or in the UK, we often use the term "man on the clapper omnibus," meaning your sort of average man on the street. Well, what is what is death, or what does it mean to be dead? And I think a lot of us almost take it for example, and you hear people answer such a question by saying, well, if you're dead. Well, if you're dead, you're dead. But I think perhaps we don't really stop to think about at what point are you classified as being dead. And that was one thing that particularly struck me when I was reading your book, that I was astounded to learn that there had been different definitions. Now, naturally, things do progress and they change over time, but something so fundamental to life, obviously, a huge part of our lives is that one day that life will come to an end. Could you talk to us a little bit about how the definitions have changed? Is there one in terms of medical or legal definitions? Is there more than one form of death? How has the definition changed? Why has it changed?
Yeah. So, for millennia, you did not need a doctor to tell you if someone was dead. People were judged to be dead at home, on the farm, on the battlefield by the absence of heartbeat and breathing. And the passage of time, the person, became cold, gray, stiff. Eventually, there would be putrefaction. But in 1968, a group of 13 men at Harvard Medical School wrote a landmark article in the Journal of the American Medical Association called "A Definition of Irreversible Coma." Now, this is a very interesting study because there's no tests, there's no scientific references, there's no evidence. This is simply the opinion of these 13 men thinking that perhaps we could redefine certain comatose people as being somehow dead already. And in fact, in the article, they never referred to these people as being dead in fact, right? They didn't say they were actually dead. They referred to these people as being desperately injured. And they said that these desperately injured people's lives were a burden to themselves and to others, and that if we would reclassify them, redefine them as being dead already, this would have the important social utilitarian benefits of freeing up ICU beds and removing the controversy about using comatose people as organ donors. And the stunning thing is how very easily and quickly societal definitions of death changed at that point. It's as if the late 1960s were pretty much right at that tail end of the paternalistic type of medicine where the man in the white coat said he knew better than you, and this was the way it was going to be, and people accepted it, as compared to 1971, when the abortion debate at the other end of life became a very hotly debated topic. In 1968, this was very quickly accepted.
That's incredible. And was that meeting of the 13 men that you mentioned, was that instigated by the government, or did it just occur? It was something that Harvard took it upon itself to do. I'm assuming there's a reason why that happened. And why was it, for example, the result of a meeting of those 13 men and not as a result of perhaps a government commission?
Well, you've heard of the space race and how that became a very big public bandwagon. The transplant race also was a very big public bandwagon in the 1960s. And these men met in reaction to the work of Dr. Christian Barnard in South Africa, who in 1967 had performed the first heart transplant, and on New Year's Day or the day after of 1968 performed his second. And so these 13 men at Harvard wanted to get transplant moving in the U.S. itself, but it was still quite controversial, what Dr. Barnard had done. So his first heart transplant was in late 1967. A young woman named Denise Darvall was at a car accident, and she was badly injured, perhaps expected to survive. So they took her heart, and they did this under a bit of a cloak of silence, but Dr. Barnard's brother Marius admitted later that they had taken Denise Darvall's heart and they had stopped its beating with a shot of potassium. It was not at all clear what they had done was legal, ethical, or moral, right? But they put that heart into another gentleman who lived a couple of weeks until he died of pneumonia. The second heart transplant, a young black man on New Year's Day of 1968, was out picnicking with his family and had a brain bleed. They brought him into Groote Schuur Hospital in South Africa, and they put a lot of pressure on his attending physician to declare him dead with a beating heart. And his attending physician wrote an article later talking about how it was very difficult for him when the transplant team came and told him they wanted him to declare this patient dead. And they said, God, Bill, what kind of a heart are you going to give us? Meaning, if you wait till this man's heart stops beating, it will be in very poor condition for transplant. So under this pressure, his attending physician did, in fact, declare him dead, and that became the second heart transplant. And when you read the background notes from the 13 men at Harvard Medical School, this was in the forefront of their thinking. They didn't think it would be enough to simply declare criteria for brain death. They wanted to be sure that this was the type of thing that would clear physicians ethically, morally, and most important, legally, so they would not be sued when they used these comatose patients whose hearts were still beating as organ donors.
Wow, that's incredible. I picked up on the terminology you used a short while ago, and you used the term irreversible coma. Now, a coma to me as a non-clinician, completely lay when it comes to medicine as a profession, that term coma to me still means someone is alive. Now, the fact that it's irreversible to me doesn't mean at that point that person isn't alive. So are we suggesting that people who are trained in medicine and surgery were accepting that a coma could constitute death if it were deemed irreversible, solely on the basis of what these 13 men at Harvard had stated? Am I understanding that correctly, Heidi?
You are quite correct. Comatose people, up until that point, had universally been accepted as being members of the living human community. None of them had ever been thought of they had not been thought of as being dead before. The criteria for irreversible is also a bit tricky, because how many times have you been at Thanksgiving or Christmas dinner and family conversation comes up about how their doctor made a misdiagnosis or was wrong and someone has survived. This happens all the time. And so irreversible, no doctor is omniscient. It's not possible really to say someone's condition is irreversible. You can make an educated guess that in all likelihood it may be irreversible, but it's not something anyone can say with absolute certainty. But in 1968 and throughout the 70s and into the early 80s, it was thought, based on people's state of medical technology at the time, that if you had a severe brain injury, you would very quickly, within the order of days to weeks, progress to cardiac arrest. So at the very least, someone with a brain injury was thought to perhaps to have a likely prognosis of death, though, of course, as you point out, they were not yet dead in fact. And there was actually an interesting study done in 1971, the first and only multi-center prospective study to evaluate were the brains of these people declared brain dead actually destroyed. Back in 1971, they actually used stricter criteria than what we use today. And what they found was of 226 brains that came to autopsy of people who had been declared brain dead, none were grossly normal. Less than half, 40%, showed diffuse tissue destruction. So the authors of this study said it was not possible to verify that a diagnosis made before cardiac arrest, right, the traditional criteria, would invariably correlate with a diffusely destroyed brain. And Dr. Gaetano Molinari, the principal investigator, asked, does a fatal prognosis permit the physician to pronounce death? He actually said he thought it was doubtful that if you could say he's practically dead, he can't survive, he has no chance of recovery anyway. He's never thought that this would be acceptable legally or morally as a pronouncement that death had occurred. But as we all know, we have accepted that. That's exactly what we have accepted. A possible prognosis of potential death is now death itself, both morally, apparently, medically, apparently, and certainly according to the law.
And that's quite staggering, because I think even though you may have a collective or a majority of doctors looking at a particular patient with their clinical expertise and experience may say it is very unlikely that this patient will recover, my thinking is that until that person has actually passed, there is, at least in theory, a possibility that they will recover. There are many cases, as far as I'm aware, where people have been incredibly unwell and then almost seem to have, spontaneously started to recover. And I think it's at least arguable that we are denying those people that, well, I say arguably, I think it's quite clear cut, really, by defining them as dead they are, excluding, of course, the current definition. We're denying them the opportunity to recover. And it seems quite staggering that as a humanity, we would do that to each other.
And you're quite right. Brain death is a prognosis of death. It does remove human rights from vulnerable neurologically injured people by the stroke of a pen. The other concerning thing to me as an anesthesiologist is it often does sentence these people to be taken to the operating room and dismembered to death without proper anesthesia. Because unlike what I was told during my training, many anesthesiologists do not use consciousness blocking drugs for these cases. They take that label, these people are dead, and they take it very literally. So I can show you review articles in the anesthesia literature that talk about caring for these people and how to protect the organs and make sure they get enough oxygenation and giving them enough fluid so that the organs will be preserved, that do not mention one word about actual anesthesia, just the use of paralyzing drugs. And I can tell you cases of people who woke up just before being taken to the operating room and who might have been subjected to the most gruesome, horrendous experience of being dismembered while paralyzed but without anesthesia.
It's absolutely staggering that we've reached this point. And I do recall some examples that you gave. I think there was an account that you told about a doctor who had asked his or her team whether they were in agreement that they were no longer going to continue. And I think asked if there was anyone present that thought they should continue. And if I understand correctly, the patient actually raised their hand. Am I recalling that story correctly?
No, a nurse, an emergency room nurse told me that story about a gentleman who they had gone through 3 crash carts full of medications trying to revive the poor man. And finally, the doctor did ask, is there anyone here who thinks we should continue? And the patient raised his hand. I mean, are not God. We can't tell if, are you dead or alive at any point in time. We can say it's likely to be futile to continue, but sometimes we are surprised.
Heidi, if we set aside for a moment the definition as irreversible coma, it is clearly the case that when people are taken to have their organs removed, they're not dead in the sense that we would have known historically.
Inward awareness is a first person experience. I cannot look in your brain and know what you're thinking, nor can you do mine, nor can we know with a patient who's neurologically injured. We can tell that they are not responding, but that's not the same as having no inward awareness. They might be inwardly aware and simply unable to respond, which is not the same thing. But the brain death exam can only test for responsiveness, which is not the lack of awareness. And this came out, would you like me to tell the case of Zach Dunlap?
Oh, yes, please.
All right. In 2007, a young man in the United States his name was Zach Dunlap. He was in a severe quad bike accident, rolled it over, severe head injury, taken to the hospital, very bad brain injury. He had brain matter coming out of his ear canal. In fact, he was so unstable that doctors were unable to perform some of the usual brain death tests. So his brain death examination hinged on a no-flow brain blood flow scan. Interestingly, brain blood flow scans and other ancillary tests are known not to be 100% sensitive and specific. In fact, when you read the latest American Academy of Neurology brain death guideline, they say all ancillary tests have shortcomings. None are 100% sensitive or specific. But because of the inherent illogic of the brain death guideline, if you're too unstable, such as with Zach Dunlap, his heart rate and blood pressure were too unstable to do the apnea test, in which the patient is withdrawn from the ventilator and observed for breathing. He could not undergo one of the brain death tests in which cold water is shot into the patient's ear because he had brain matter coming out of his ear canal. So in his case, because of the illogic of the guideline, his brain death diagnosis was 100% dependent on a brain blood flow study, which is known not to be 100% accurate. Well, thankfully for Zach, his cousin did not believe that he was dead. His cousin was a nurse from another facility and came in and saw Zach. And he took his closed clasp knife and he scraped the bottom of Zach's foot, and Zach withdrew his foot. So the cousin called the nurse, come look, my cousin is moving. He's not dead. And if you watch the video that's linked on my website, you can see the cousin tell this story. Zach's ICU nurse came and said, well, in brain death school, they tell us they can still be moving, but they're dead. Zach's cousin then gave another painful stimulus. He smashed Zach's nail bed, and Zach pretty much took a swing at him. And at that point, the nurse said, oh, that movement crossed the midline, so that one counts. Let me call the doctor. And so here the helicopter was just landing with the staff to remove Zach's organs when the whole thing got called off. And even worse, Zach later was able to report that while laying in that ICU bed, he heard every word. He said, I was laying there in the hospital bed, unable to move, unable to speak or sign, and I could hear the doctors saying to my parents, he's brain dead, he's passing away. And there was nothing I could do. I couldn't move, I couldn't sign, I could only get extremely angry. And so again, this brings up my point that, if not for a cousin, it wasn't Zach's medical team that found that he was not dead. It was Zach's cousin. If not for his cousin, he was about to be taken to the operating room to be dismembered without possibly the anesthetic that would have been necessary for him not to hear things. I can't imagine the horror that he would have experienced. And I know because Zach was able to report it that this does happen. And I know there are people who have gone through this that weren't able to be saved in time. And that's what motivates me to speak, to write, to try to help people understand this is a redefinition of death. This is not death itself.
So Heidi, when you as an anaesthetist, as we would use the terminology in the UK, when you give an anaesthetic to block consciousness, can I just dig a little deeper into that? I mean, when we're talking about blocking consciousness in this context, is that medication what would stop that person having an awareness that their organs are being taken?
So in modern anesthesia, we use what's called a balanced anesthesia technique because, in the old days when people would be given halothane, ether, cyclopropane. The amount that you would need to give to achieve lack of mobility, the patient wouldn't be moving during surgery, was a heavy dose. And people wake up feeling absolutely ghastly and miserable, which nobody likes after surgery. So now in modern anesthesia, what we do is we give a paralyzing drug, something like poison dart frog, curare idea, right? And then because the patient won't move, we can try to give a lighter dose of pain-killing and consciousness-blocking drugs, so to keep people comfortable, but have them be able to wake up without feeling so drugged and so sick to their stomach and so miserable. And so that's why we have the option now. It's sort of like we give a smorgasbord of drugs, and that's why some anesthetists choose, why would I give a consciousness blocking drug to a dead person, leaving that possibility of someone being awake and aware but paralyzed and unable to move during a surgery?
So there is the possibility that someone who isn't given a consciousness blocking drug, that they may actually be aware of what is happening, even though, as you say, they've had the medication paralyzing them. They obviously can't do anything about it. But it is a possibility, if I'm understanding correctly, that they could very well be aware of what's happening to them.
Oh, yes. See, this even happens during routine surgery. Sometimes we guess wrong, perhaps, and people will report that they were unable to move, but that they were aware during their surgery. I remember a case from my training. A gentleman was very unstable, and because of his very low blood pressure, a very little consciousness blocking drug was able to be used. And later on, he reported being quite offended by some of the jokes being made in the operating room and the levity during his case. So people have this happen fairly, I wouldn't say routinely, but it happens fairly often.
Thank you. And just perhaps as another illustration of the fact that these scenarios are coming up with relative frequency, could you share with the listeners the story about Misty Hawkins and what happened to her?
Yes. So in the early 1990s, a different way of becoming an organ donor was pioneered. So there were not enough organs being procured through brain death because brain injury is not all that common. So it became thought that perhaps we could take someone who is not brain dead and make them an organ donor. And so this is called donation after circulatory death, or DCD. And in this protocol, these people, again, are not brain dead, but they have a poor prognosis. They're not expected to survive. So they are given a do not resuscitate order. This can be done by the doctor and family, or it can even be done by the patient themselves. If the patient has decided their quality of life is unacceptable and they would like to have their care withdrawn in a way that allows them to donate organs, this happens as well. So again, this is a death planned to occur at a specific time and place so that organs can be harvested. They could be resuscitated, but they have opted not to be. Of course, in the U.S., our law says that to be declared dead, you have to have the irreversible cessation of circulatory and respiratory functions. These people honestly do not meet the standard of the law because their condition could be reversed. It's simply that a decision has been made not to do so. So what happens is they're taken to the operating room, care is withdrawn, and they become an organ donor. Let me tell you how it happened with Misty Hawkins, now that I've given the background on that. So Misty was a young woman with a cognitive disability. She choked while eating a sandwich at home and was brought to the hospital, but because of the lack of oxygen to her brain, she had a severe anoxic brain injury. She did not meet the criteria for brain death, but doctors told her parents that they did not expect Misty to have a good long-term outcome. They didn't think she would recover, and they offered her parents the opportunity of withdrawing Misty's care in such a way to allow her to become an organ donor. And Misty's parents didn't want their daughter to suffer, and they would like to think that perhaps some good could come out of their tragedy to help someone else, so they agreed to this. So Misty was taken to the operating room, and her ventilator and her care were withdrawn. It took 103 minutes for her heart to stop beating after that. The hospital then gave her a 5-minute, what's called a no-touch period. In the United States, there's no universal standard. It's usually from 2 minutes to 5 minutes of observing. Once your heart stops, will you automatically resuscitate, right? It's sort of interesting to me that whether you're dead or alive depends on your geography
Mhm.
rather than upon anything else.
So
But
that's a
in that state,
that's state-based, I presume, the 2 to the 5 minutes. Depends which state you're in.
yeah, that's right.
Okay,
In
thank you.
Wisconsin, it's just 2 minutes. In her state, it was 5. So after a 5-minute no-touch period, Misty did not spontaneously resuscitate herself. So organ procurement surgery began. But when the surgeons sawed through her breastbone, they found her heart had resumed beating, and she began gasping for breath. So the surgeons waved off. They departed. Another doctor was found to stitch her up. It's not clear if she was ever given any anesthetic during this interval. And a few minutes later, her heart stopped beating again for a final time. But as horrifying as that is, what really also bothers me about Misty's case is that her family was never told. An organ procurement coordinator called Misty's mother on the telephone and said, "It's too bad. It just didn't work out for Misty to become an organ donor." And in fact, her family was not informed about what had happened to their daughter until a year later when reporters from the New York Times approached them for comment and told them the facts. As a mother, I can't imagine knowing the horror that daughter went through and the fact that you were never told. There is such a conspiracy of silence about this.
Yes.
It's like what happens in the OR stays in the OR. There's a complete lack of transparency.
Thank you for sharing that with us. So I think so far we've established that the definition has changed. You very kindly explained the rationale for that definition change. So I think the next question that is perhaps obvious to ask is what's behind this? What are the objectives? It seems an increase in obtaining organs, but what benefit? For example, if you have organs being removed in a hospital from one patient and placed in another, where is the benefit? Why is the system comfortable in bringing one patient's life to an end to help another? What's the benefit in that, aside from arguably the benefit to the recipient?
Well, I didn't, in the past, historically, I have not liked to bring up the money aspect of this. I think most people who are involved in organ procurement are driven by a sense of zeal, wanting to somehow do good for others. So I don't like to impugn everybody's motives. But I was recently on a podcast with another guest whose family member was given for organ harvesting and later found out the amount of money that was made on that body they gave away for free. And it was very important to her. This bothered her a lot. So because it was important to someone who was actually touched by this, I have been a bit more forthcoming about the dollars and cents. In 2025, just this year, the Milliman Actuarial Company came out with their transplant report, something they do about every 5 years. And according to the numbers that they generated, if you look at all the billable charges in the U.S. for organ transplantation in 2025, it adds up to be about a $60 billion with a B dollar industry per year. They have a chart where you can look at, if someone gave their heart, their lungs, their kidney, their liver, their intestine, their pancreas, that one person's body just for those organs can generate $8 million in billable charges. And that doesn't even count the tissues, things like skin, bone, fat, heart valves, cornea. So again, the body you give away for free is worth a lot of money to the medical system in billable charges. They say follow the money. Whereas I don't know that this is 100% the answer to your question, it certainly contributes.
Absolutely. And that was my thinking. Was there a clear financial aspect to this? To be very honest with you, I had thought perhaps there was a price put on the organs themselves. It hadn't crossed my mind that we were looking at billable charges, and I'm perhaps looking at that from a person's point of view in the UK, where we have the National Health Service, and you wouldn't necessarily be paying medical fees or surgical fees unless you chose to go private as such. But when you're talking those sorts of figures, I think you could be forgiven for suggesting that there are monetary objectives there. Because and for the life of me, I can't remember where, but placing a financial value on body parts, I had heard that even a placenta after birth has, if my memory serves me correctly, we're talking tens of thousands of pounds in value. Have you heard anything along those lines, Heidi, in terms of things like a placenta after birth? For the life of me, for some reason a figure of £100,000 or dollars is in my mind. Would that seem to be a rational figure in your experience?
It would not surprise me one bit. There was an interesting article written by reporter Melody Peterson of the LA Times a few years ago, and she was just talking about tissue donation. And this is another point for people to consider. Organs, things like heart, lung, liver, kidneys, really need to come from someone who is still biologically alive, because organs, being the complex structures that they are, very quickly begin to break down in the absence of circulation, bringing them oxygen and nutrition. Whereas tissues, things like skin, bone, cornea, heart valve, fat, these are more simple structures. They're more resilient to the loss of circulation and oxygen, and they actually can be donated from a biologically dead body. But what Melody Peterson found in her report in the LA Times was that these tissues very often are not going for life-saving surgery. They're often used for cosmetic procedures. And she had a graphic showing a half a teaspoon of ground up skin to fill cellulite dimples. I believe it was worth something like $400 for a half teaspoon. I mean, very high billable charges for things that are used to enhance parts of people's bodies, plump posteriors, things like this. And so when people are donating their body thinking they're going to be doing something life-saving, I think they should be informed that this is not always the case.
Absolutely. And with reference to organ donation, is it the case? Is this an international issue? So, is it possible for organs to be taken from a donor and used internationally, or would the logistics make that prohibitive? And we're just talking about perhaps patients in the same hospital. And we're talking about monetary figures. I think we perhaps always need to consider that it's possible that there is a commercial demand that's driving this, particularly if there's an international market. Are you aware of organs being used internationally?
There was just a very interesting case that was reported in Canada, our neighbor here to the north. They allow euthanasia organ harvesting for people who have decided they want to have their life terminated, and then give their organs as part of that termination, something that is not allowed in the United States. We don't have a law that allows active euthanasia that way. But a Canadian euthanasia patient's heart was then taken to the U.S. and put in a U.S. patient, I believe in Philadelphia or in Pennsylvania, which brings up a lot of questions. Was there no one in Canada who needed a heart transplant? Why are American insurance dollars going to pay for this heart that was shipped from Canada under circumstances that are not considered moral or legal here? So yes, this does happen.
And am I right in recalling that there are cases where inmates on death row are contributing their organs as well? I believe I recall you talking about people them being able to bring in the recipients at particular times because they know that a life is going to be brought to an end and organs are going to be taken. Is that going on as well, as far as you're aware?
This is ongoing in communist China right now. There's a horrendous practice there of using political prisoners who are perhaps practitioners of Falun Gong, prisoners who are Uyghur Muslims, prisoners now who are house church Christians or other political undesirables are incarcerated and are forced to undergo blood and tissue typing. Their organs then are put on the market, and transplant tourists come from all over the world to have their transplant on the day that that political prisoner is executed via organ harvesting. This is well documented. I recommend to your audience the work of an organization called Doctors Against Forced Organ Harvesting that has done the lion's share of the work in raising awareness about this. Now, in certain countries, this actually has been made illegal. Certain European countries, and I believe in Israel also, it is no longer legal for insurance companies to pay for organs procured in China because of this. Unfortunately, in the U.S., except for a handful of states, 4 or 5 states have banned this. In general, American insurance companies will pay for these organs taken from the execution of a political prisoner. It's horrific.
Absolutely. And I understand when I've had discussions in this area with people I know, one of the points that is often raised is, and in part, I think there's partly it's in jest because it's a difficult subject to talk about, and some people find comfort in humor. So they'll say to me, "Oh, well, I don't have to worry about that because I've got cancer, so I wouldn't be any good to anyone." But my understanding is that that's not actually true, and that in the international setting, organs can be taken from a patient who would be classified as being unwell, perhaps with a disease such as cancer, and organs from that person can still be transplanted into someone else. Are you aware whether that is correct?
Yes, I was just reading an article written by an organ procurement team from Pennsylvania, and they were saying how the new thought is that no organ is too old or too sick to become a transplanted organ. They were saying that if you have cancer, well, we could put that organ in and then treat the recipient for cancer. If you have AIDS, there are people who have AIDS that might want that organ, or you could just treat the recipient for AIDS. They were saying that they've taken organs from people in their 90s. In this article, believe it or not, they actually boasted about taking a heart with coronary artery disease and transplanting it, thinking they could treat the recipient for coronary artery disease. So that is the new thinking, that no organ is too old or too sick to be used for a transplant.
Are there specific factors which make an organ more valuable? So, for example, the age of the donor, and I hate to raise this because it becomes even more sensitive when you bring children into the equation, but would the organ of a child be typically more valuable than the organ of an elderly person? Or if you're a particular sex or you're from a particular race, does that make your organ more valuable? Perhaps again, I'm just thinking about basic laws of demand and supply.
Yeah. Organ transplant hospitals are judged on their 1-year survivability after transplant. So yes, they are aware of these things, and they will, certainly preferentially try to use the best organs they can. Not that they won't use others. That people do have a sense, and when I talk to people in the community, that they don't want to be a registered organ donor for fear that they might be looked upon as a good candidate, particularly younger people. I've talked to families who, a friend of ours had a young football player, unfortunately, who had a head injury, and the family was absolutely aghast how quickly the discussion turned away from how can we protect and preserve your son's life to, wouldn't it be great to make your son an organ donor? This idea has divided doctors' loyalties. If I'm in the hospital, I certainly want my healthcare team to be thinking about how to protect and preserve my life. I don't want to have them looking at me as better off dead.
Absolutely. And that actually brings me on to a point I'd be very interested to compare what's happening in the UK and the US. I have been told by someone who works in a hospital, I'm not going to disclose them because they still work within that setting now, but they have told me categorically that within the accident and emergency department of every hospital in the UK, there is a clinician. They've stressed, usually a nurse, but not always, that their sole role is to identify possible donors as they come into the accident and emergency room. Have you heard about any similar arrangements being in place in the US? Is there sort of a mechanism whereby, for example, if someone comes in, transplant team must be notified either by law or by procedure?
Oh, yeah. So in the United States, hospitals risk losing their state Medicare and Medicaid funding if they do not report everyone who might potentially become an organ donor. You don't have to be brain dead yet. They are required to report to organ procurement organizations whether someone is a potential organ donor. And then the organ procurement people are allowed to come in and they're allowed to view that patient's what should be personal private medical record so that they can begin to take steps to make that happen should the person's condition deteriorate. So yes, indeed, that happens by regulatory law with our Medicare and Medicaid rules here.
Do we know what protocols or procedures are in place? How do they determine who could potentially become an organ donor? Because I'm assuming that theoretically, at least, anyone that comes into the hospital could be a suitable donor, but does their condition have to reach a certain point of deterioration before that decision is made?
I believe it's quite subjective. I think it's people who appear to have a poor prognosis, and that's the end of it.
Thank you. And the system that you have in the US, Heidi, again, just to sort of compare and contrast between the US and the UK in terms of how things are now, do citizens of the US have an opt-in or an opt-out donation scheme, or perhaps that's even another state governed issue?
That's interesting that you bring that up. I just was sent, one of my website followers sent me an article that was just out today about the UK and that they were saying after 10 years of having your opt-out system, there really has not been any change in the amount of organs donated, which I found fascinating. But in fact, in the United States, officially, we have an opt-in system. So officially, you must declare that you want to be an organ donor. In the background, however, there's a law that not many people are aware of called the Uniform Anatomical Gift Act. And this law states that if you come into a hospital and you're incommunicative, unresponsive, and your family cannot be found in a timely manner, the hospital administrator is empowered to donate your organs and your body on your behalf unless you have a specific refusal. Whereas publicly, we have an opt-in system. Officially, behind the scenes, you actually have to opt out. You have to have a specific refusal. And not one person in 1,000 knows about this, but that's one of the things I'm trying to make people aware of, that even in the US, in that unlikely chance that you come into the hospital and you can't talk and your family can't be found, you are considered a donor unless you have specifically registered a refusal.
That's very interesting because here in the UK, we historically had a scheme where you had to opt in and people would carry a donor's card with them to indicate, obviously, to the hospital that they were willing to be a donor. As I'm sure you're more than aware, the UK is obviously made up of technically what are separate countries, being England, Wales, Scotland, Northern Ireland. I'm based in England. Our law changed in May 2020 and we became an opt-out scheme from that point. Wales, I believe, was December 2015 and Scotland was March 2021. But the interesting thing that I discovered, and I certainly wasn't aware of this, and I wonder how many of the listeners will be aware, that even if you have opted out, the driving license scheme in the UK, actually, I would encourage the listeners in the UK who hold driving licenses to look at the back of their driving license and down towards the bottom left-hand corner. They might see 3 digits, namely 115. And that's all you'll see is those 3 digits. Apparently, and I have verified this with the DVLA, so even if you have opted out of organ donation and you are no longer a register, if your driving license has those 3 numbers on the back, you would still be classified as a donor. That would particularly be the case if you were taken into an emergency situation, perhaps you've had a bad car accident or something like that, they would naturally have perhaps your driving license in your purse or your wallet. And if they see those three numbers, that would indicate to them that you're a donor. So if you have removed yourself from the register and you check your driving license and those three numbers are on the rear of the driving license, you need to contact the DVLA to have that changed. Otherwise, you could be treated as a donor regardless of your wishes. So I think in light of what you've said, Heidi, may I just ask, what are the factors, do you think, that are stopping more clinicians speaking out about this situation? It seems to be that perhaps people are, to coin a phrase, that they're going along with it. Is that for fear of destroying their careers, or are there other factors at play here?
No, very much your job is at stake. One of my friends, a fellow anesthesiologist, Dr. Gail Van Norman, wrote 20 years ago for anesthesiologists her concerns about the brain death diagnosis. And she was brought up on ethics charges, and 3 transplant surgeons tried to get her fired from her position because of this. Another anesthesiologist, Dr. Bill Perez, wrote in the Linacre Quarterly that it's very risky to question the system because your job might be at stake. And I have many good doctors who are still working, who do speak publicly about this, but I have other doctors who are willing to support my work from the shadows. They'll review my articles and my papers, and they'll make good suggestions. But when I ask them if they want to put their name on the article along with me, they'll say, Heidi, I have kids in graduate school. I need to work 2 more years. There is a conspiracy of silence. I know nurses, they make lateral moves. They can no longer stomach working in the ICU seeing this happen. So they changed to work in the outpatient clinic. I have another fellow anesthesiologist who stopped working, taking night call, except in the maternity hospital. So she would just be doing now labor epidurals and would never be called upon to participate in organ harvest. So people are aware of it. People make lateral moves. People, try to do what they can behind the scenes, but they do face loss of livelihood for speaking up, which, again, I can do this because I'm fully retired. It makes it much easier for me.
Okay, thank you. And I suppose that the question that the listeners would perhaps want to put to someone with your experience and expertise, if they could ask the question, I'm anticipating that someone would say to you, do you recommend being on an organ register, or do you recommend that people opt out? I appreciate that's a very personal decision for people, and you and I are not here today to tell people what they should do, but rather present the information to them, because as we established from our previous conversations, you and I both strongly believe in true informed consent. So obviously, before you can give true informed consent, you have to have the information in front of you. But I would imagine that's not the first time you've been asked that question. How would you generally respond?
Yes, I completely agree. I mean, we need full transparency. How can anyone make a fully informed consent unless they're given the facts? But right now, there's no effort at any type of information process. People are simply given slogans, and they're told, would you like to become an organ donor, without being told anything about the process? So yes, we need full transparency about this. The fact is that organs can only come from someone who is biologically alive. And so I would never recommend for anyone to be a registered organ donor. As far as tissues, I mentioned that, tissues can be ethically donated from a biologically dead body, but I would not register for this as well. And this is the reason. I mentioned the Melody Peterson LA Times article. What she found was registered organ donors were taken for tissue harvesting before a coroner's autopsy. This led to death investigations being upended. In one case, a young man's family was never able to learn why he had died suddenly because he was a registered donor and his heart was taken apart for heart valve harvesting. So the pathologist later on autopsy couldn't tell had he had a heart problem. Another family, their daughter was apparently the victim of assault and battery, But because her daughter, again, was a registered donor, after bone and skin were removed, the coroner could no longer look for bruises or fractures. And so her homicide investigation was upended. So I really recommend that people not be registered donors. I'm not opposed to tissue donation. I think it's something that people could do. But if you want to donate things like corneas, skin, bone, heart valves, just tell your family. Once, all their questions have been answered about your death and they're sure your death isn't the result of a crime, your family can release these things for tissue donation if you would like. I'm really, strangely enough, you might be surprised to learn, I'm not opposed to transplant in entirety. I think living donation, in which both the donor and the recipient remain alive after the procedure, is a wonderful ethical way of helping someone in need. I have a personal friend where the mother gave a kidney to her young daughter. Her daughter's now lived for over 20 years. I think this is a wonderful thing, but the unethical parts of organ transplantation should be exposed and people should be able to make a fully informed choice.
Absolutely. This, again, as we previously discussed, this isn't this conversation isn't us judging anyone, and we both have sympathies for people that perhaps are listening to this and they've either been party to a donation or a loved one has, and they're now having second thoughts. So we just wanted to stress that we're not here to judge anyone. And this conversation is really about getting the information out and giving people a launch pad to research themselves in greater detail if they would like to.
If I may expand on that, I want to echo what Bill just said. I tell people, if you're a doctor or a nurse, the amount of knowledge you're responsible for is so vast. There's no way you could possibly personally investigate everything you're taught. You're forced to take things on authority, as I was back when I was in my training. So again, it is not your fault that you've been taught these things and you were brought up in a culture where this is acceptable. It's important for you to know that it's not your fault. Also, people who have given a family member to become an organ donor, it's not your fault that you were deceived, that you were not given all this information at that time. You made the best decision you could with the information you had available at the time. And particularly if you've received an organ, I'm glad, we're all glad that you're here. Your life is as valuable to us as anyone else's, and we have respect for that. And again, it's not your fault that the organ you received may have been procured in a way that might now violate your conscience, knowing the facts. But we need to speak the truth in love to one another going forward. We need to shine the light on what's going on so that we can make better decisions, we can fund better research, and have better options available in the future.
Thank you, Heidi. I'm very conscious of your time. I know that you have another engagement today. If I may just quickly mention in passing, when all of this information that we have discussed today came to light, one thing that struck me very hard was I thought, we've got all of this going on that we don't know half of what's actually going on behind the scenes where we're not told this information. And all of this is happening at the time where in the UK, we have an assisted dying bill currently going through Parliament. Now, I was very concerned in light of the information we've discussed today to see that whilst this bill is going through the UK Parliament, we have already seen a major safeguard being dropped from the legislation. And that was initially that before a life could be brought to an end, my understanding was that it would have to be signed off by a High Court judge. That safeguard has already been dropped and the legislation is not yet in force. In my mind, I'm thinking, and I'm admittedly here, perhaps people are thinking that I'm being too cynical, but my brain immediately goes to the fact that when we're seeing this drive to find organs, is this connected to assisted dying? You mentioned the Canadian case earlier on, Heidi, and I'm very aware at the moment that Canada is much further advanced than the UK in terms of this legislation is already in place. Assisted dying is happening in Canada. And I'm hearing very alarming stories of very young people that I would personally classify as children getting involved in this assisted dying because they're suffering from conditions such as severe depression. I've heard stories of children with autism being put forward. And I just find it absolutely horrific that humanity is, I say, allowing this to happen, but clearly there is trust in the system. People are not actually looking. And I think this is something that you and I haven't discussed before, but I certainly wouldn't be surprised if in your endeavors to make this information available to people, you've faced a weight of opposition, perhaps from within your profession, but also just in your personal life, perhaps people saying, oh, this type of thing, it can't be happening. You're mad, because part of it is maybe they just don't believe it. Part of it is they just cannot comprehend that something as horrific as this could actually be going on. But I'm very concerned about the fact, are these assisted dying bills that we're seeing come in, particularly within Western society, if I can use that terminology, at times when we know that there is organ harvesting. Do you have any final thoughts along those lines?
Yes, what I find very disturbing is that your society, your government might tell you that your life is worthless, but your organs are valuable. That dichotomy really troubles me, and I think it's misplaced. And so we have to guard against that. I think we have to return to our Western civilization's roots, and that every person's life is valuable and worthy of support, no matter how disabled they are. We need to give the respect due to their individual, inimitable, unique life and try to support them in every way that we can. This is a problem, as these assisted dying bills are pushing the opposite view, that you're only as valuable as your contributions to society. This is not our traditional Western civilization view, and I think it needs to be resisted.
Thank you for sharing that with us. Now, I'm very conscious of your time pressures now. So just in closing, I'd just like to let the listeners know, and anyone that's watching this rather than just listening to the audio, this is Heidi's book. Highly recommended. It's a fascinating read. I'm aware the book, I believe, certainly is available on Amazon. I believe it's available on your website as well. Would you like to just close telling the listeners where they can find out more about the work that you're involved with, please?
Yes, thank you so much, Bill. I appreciate the idea that, yes, we were all brought up to think a certain way. I was too, but it's worth taking a second look at something you thought you knew. And so I do make these resources available. So the website is called respectforhumanlife.com. Be sure to put the human in there or you won't find us. Respectforhumanlife.com. You can find me on YouTube at Heidi Klessig, MD. I have a short series of videos for people who want just a 5-10 minute look at certain topics like brain death, circulatory death, the horrific practice of normothermic regional perfusion, which we haven't had time to discuss today. Also, I'm on X at Heidi Klessig, MD. I try to keep people updated about new developments in this field just about on a daily basis. So thank you so much.
Thank you. Well, Heidi, as I say, I am very conscious of your other commitment today. I cannot thank you enough for coming on today to discuss this very important topic. And I wish you the very best of luck at the work that you're doing. But thanks once again. It's been an absolute pleasure speaking with you. Bye for now, Heidi.
Thank you, Bill. Bye-bye.